sit in OPDs or your practice, or in your, if you're sitting in the casualties or in OPDs, anywhere, this movement disorder is something which you routinely get consultations. Like you may get a consultations from your nephro patient or some other patient telling that the patient is tremor or some involuntary movement. So involuntary movements is always a bit confusing for a physician or a clinician, because first of all, you have to find out what movement it is. So I am going to tell you not the theory things and all. I'm just telling you how to identify these movements. If you want to know in detail about this movement disorder, you can go and watch the major module where I discussed about involuntary movements in as 4 or 5 modules. So 4 or 5 videos. So hyperkinetic movement disorders. When you discuss about hyperkinetic movement disorders, you have a lot of movements, like you have tremors, your myoclonus, your chorea, dystonias. So out of all these movements, if you ask me, the most important or the most common movement which you are going to see is tremors. So I will discuss more about tremor, but the problem is that many other movement disorders may looks like tremor, but all of them are not tremors. Like dystonia can have some tremorless movements which may looks like tremors. Myoclonus may also looks like tremors, particularly when it is slow myoclonus or sometimes it is a negative myoclonus. It may looks like a tremor. So you need to identify like what is a movement disorder when you are going to see the patient. So I will try to enact some of the movement disorders in this module, and I will show some videos also which I have in my own patients, and some of them are actually interesting, and so you will be able to make out what is happening. So your idea about approaching a movement disorder, a hyperkinetic movement disorder, should be: one is what is a movement, second, what caused the movement, whether it is an acute movement, then you should think of the drugs. Majority of the times the drugs are the culprits, especially when the patient is IP. Second, whether it is because of metabolic, because these are treatable things. Then you keep your diagnosis like interesting tremor syndromes or genetic diagnosis. All those things will be interesting to you, but it is not that interesting for the patient because it is not curable. So always keep such diagnosis down the list. Always take the common treatable things, because your idea is not to diagnose the patient. Your idea is not to feel the happiness in diagnosing the patient. Rather, your idea should be happiness in treating the patient. So your idea should be identifying the movement disorder and treating them. So you should always keep in mind whether there is any drugs. Check the drugs. If you don't know, like sometimes the patient's chart will contain lot of drugs. Some of the drugs you don't know the side effects also. So sometimes you have to go to the net and search whether this drug causes tremors. But the problem about that is when you search in the net, almost every drug will cause tremors. Almost every drug will cause some movement disorder. So the most important part is what is a movement. Then you can correlate it much better, and then you can plan your treatment. So that is the most important part when you are seeing the hyperkinetic movement disorder. If you take the hyperkinetic movement disorder, I told you it can be tremor, chorea, balismus, dystonia, myoclonus, tics, and akathisia. So the first of all, when you see a movement disorder, you should identify whether it is rhythmic or not. So the first step should be whether the movement what you are going to see is rhythmic or not. That is a first step. Rhythmic or not is a first step. Then second step is whether it is repetitive. Repetitive, same movements is happening. Actually, rhythmicity means repetitively, and whether it is predictable. Then you should see whether it is involving how many axes. Suppose I am having a movement like this. This is only in one axis, while this is a multi-axis movement. So what all axis it is involved? Predictable or not? Axis is it involved? Then what all joints is involved? Whether only one joint, two joint. If a joint is involved, what movement? Whether it is a flowing movement from one joint to another joint is happening. Then the sixth step is what are the aggravating or relieving factors, and what happens in sleep and rest. Sleep, rest, or actions, or any stimulus. So these are the basic things what you are going to see in a movement. Even if you are not remembering these 1, 2, 3, 4, 5, 6, 7 and 8, that doesn't matter. For me, when you see a movement, you just see the movement and see what is happening. It's just in front of you, it is there. In a glance, you can see and find out what all movements or what all joints are involved. Just see and try to describe it. That's all. Even if you are not like, I'm not a fan. Like if you open Harrison, you may see some tables like it is given approach to peripheral nerve 1, 2, 3, 4, 5 points. Don't remember these point things. Just understand the subject. Just understand what is happening in the physiology. Then go with that. So suppose I'm going to explain about tremor. This is what is this? This is unidirectional. Which joint? My wrist joint. It is only up and down, only one axis. And it is repetitive? Yes, it is repetitive. Is it rhythmic? Yes, rhythmic. Why it is rhythmic? The upward movement and downward movement is almost same amplitude, and upward movement and downward movement is almost same speed. That is known as rhythmic. And you can predict it. Once it goes down, the next movement will be up, then down, then up, then down. So this movement is rhythmic, predictable, repetitive movement, or you can also call it as oscillatory or whatever it may be. So it is rhythmic, very smooth movement, and predictable movement, repetitive movement. And what axis? Only one axis. And what joint? My wrist joint. What movement? Flexion, extension of wrist. So this, whether it is increase on movement, if it increase on movement, whether it is decreasing on movement, or what are the other aggravating and relieving factors, and what happens in sleep. That is what you are going to see. So a tremor is a rhythmic movement. Tremor is always rhythmic movement, and it is in one direction, repetitive, predictable. So tremor is rhythmic. Each movement up and down is almost similar amplitude, almost similar speed, and it is predictable. You can predict it. If it goes down, next is goes up, down, up. So you can, when the hand is up, you can predict the next one is down. So that is predictable. It is in only one axis. If it is in multiple axis, it is not tremor. If this movement is there, it is not tremor. Tremor cannot be multi-axis. Multiple direction movement in the same joint cannot occur in tremor. So suppose this is also single axis, right? Is it tremor? No. This is arrhythmic, because you can see this, it is breaking here and there. It is not smooth. It is not equal amplitude, equal velocity in all the movements. So it is not rhythmic. That sort of tremors can occur, and sometimes you will see dystonic tremor. When you keep the hand outstretched, you will see some tremorlessness which is not rhythmic. That is the dystonic tremor, or sometimes myoclonic tremors. So these are other tremorlessness like movements which mimic a tremor. How you differentiate is whether it is repetitive, whether it is rhythmic, whether it is predictable. These are three important points. And fourth one is what is the axis. And then you can tell which joint, what movement, and aggravating relieving factors, sleep, rest, actions, or other stimulus, what is happening. These things you can tell. But definitely the first four things, that is very important. So that is tremor. So tremor is repetitive, rhythmic, predictable, uniaxial or unidirectional movement. So that is known as tremor. What about chorea? Chorea, you see, this is chorea. Chorea, you see, I get a moment here, then I will get a moment. First moment is on the wrist, then second moment may be in the fingers, then in between the elbow, then shoulder, then suddenly again comes back to wrist. So you cannot predict after the wrist movement, next movement, you cannot predict that it is next is going to be elbow. So it is not predictable, and it is not rhythmic. It is not smooth, very rapid, haphazard movement. So it is non-rhythmic, non-repetitive, non-predictable. And axis, it is multiple axis. It is this axis, this, that. All these directions, it is multi-directional, multiple axis involved. Then and it flows from one joint to another joint. This is chorea. Chorea, that is why chorea looks like breakdance. That is why it is known as dancing like movement. So chorea or choreiform movements are arrhythmic, non-repetitive. You cannot predict after this movement, this may not be there. If you see first chorea like this, next episode of chorea after this, you will see facial movements. So that is non-repetitive, non-predictable, arrhythmic movement and multiple axis, and it flows from one joint to another joint. If you next time you see a chorea, go and watch it very carefully. The choreiform movements are arrhythmic, sudden movements, in between slow movements, and very non-repetitive, non-predictable, flow from one joint to another joint, and axis is multi-axis or multiple directional movements will be there. That is what is chorea is. So tremor, chorea difference you understood, right? So what about athetosis? Athetosis is also something which mimics like chorea. So athetosis is more distal, and there is small writhing movement. This movement will come, and unlike chorea, the athetosis is more predictable, more repetitive, because Athetosis, you can at least predict this movement is going to repeat again. So that is why nowadays it is not separate as a single, it is grouped as a single movement, chorioathetosis, not as two different movements, because usually they overlap. The chorea patient may have some athetotic movement. Sometimes athetosis may have a major movement. So, but they will have some amount of choriform activities will be there. So that because the pathogenesis, the pathology is from the caudate nucleus. So that is why chorioathetosis is the name what is given right now. So athetosis is slightly more distal than chorea and more predictable and more repetitive than chorea, but not as predictable and repetitive as a tremor. So that is chorea. So balismus is the proximal large amplitude. The amplitude of movement is very large. Large amplitude flinging movement involving the proximal joint, that is known as balismus. So tremor, chorea, balismus. Balismus also is very random, arrhythmic. Again, non-repetitive. You cannot predict it. When it comes in between the gap, you cannot predict. So that is the balismus. So chorea, balismus, tremor we completed. So what about dystonia? I'll discuss each movement separately, but first of all, you should understand how to identify the movements. So what about dystonia? Dystonia is by definition, dystonia is a sustained contraction of the muscle. Sustained contraction of the muscle, which results in movement or posturing or both together. So this one is suddenly I am getting a sustained contraction. So dystonia, among the whole movement, that is the slowest movement. Sustained contraction. Sometimes dystonia is associated with pain because of muscle contraction. Sustained contraction which results in posture, or sometimes it can present tremors, tremorlessness movement. This can occur. So that is again, is it rhythmic? It's not rhythmic, it is arrhythmic, but it is patterned. Arrhythmic means the movement, the upward movement, downward movement, every movement is not rhythmic, not oscillatory as tremors, but it is much more jerkier this there. But it is patterned. If a dystonia is happening like this, every time dystonia is going to happen like, suppose if somebody has cervical dystonia, this happens. The cervical dystonia, once it happens, always it is same pattern. So that is known as a patterned movement. But it is slightly arrhythmic, slightly, it is somewhat repetitive, but it is not as predictably repetitive as a tremor. Tremor you can predict after up, then down will come, because the gap between each movement is constant. But here it is, this movement will happen, sometimes it may relax, sometimes it may not relax, sometimes after some time it will be triggered. So that are the features of dystonic tremors or the dystonias. So we discussed tremor. Chorea is arrhythmic, multiple joint, flowing of movement, dance-like movement, and you will get multiple axes involved. Balismus, athetosis distal, more rhythmic type of movement. And what about balismus? Balismus is proximal, flinging, large amplitude movement. Again, very arrhythmic, very not that repetitive, but it is more repetitive than chorea. Chorea is the most random of all these movements. And dystonia, it is patterned contraction, patterned movement associated with posture or movement or both. So what about myoclonus? Myoclonus is the fast, myoclonus and tic, these two are the very fast movements. So this sudden movement, whenever you say sudden, so you have to see the speed also. So rhythmicity, rapidity, predictability, access, all those things, plus speed of the movement also is very important. So myoclonus is sudden jerky movement, sudden jerk, the sudden electric shock like sudden jerks. So that is the classical myoclonus. So myoclonus is sudden. So sometimes you will see this jerky tremorlessness. So that tremorlessness, you see, that is very arrhythmic, very arrhythmic. That is, myoclonus is again non-repetitive, arrhythmic and jerky, and somewhat predictable, sometimes not predictable. You can sometimes myoclonus is repeatedly happening. Sometimes I'll show the video of such non-predictable random multifocal myoclonus. So I'll show it later. So that is myoclonus. So tics. So tics also sometimes looks like myoclonus. So tics, what? This is tics. Tics are more common in childhood, but you can see tics sometimes in adult also. Sudden jerky like movement, but it is more suppressible than myoclonus. Myoclonus, if the patient want to control and suppress it, tics to an extent, patient can control it. But all other tremor, chorea, balismus, dystonia, myoclonus, these are actually involuntary movements. which cannot be controlled. But tics is, you can call it as involuntary movement, involuntary movements. It is given in the old Dijon. It is given as involuntary movement because it is partially suppressible, partially controllable. It is not a pure involuntary in that sense. But to an extent, after some time, because of the inner irritability, they again have to show it. And they are semi-purpose. This was a movement happening, the tic, and my body was, I was trying to convert it into a movement to cover it up. So that is, this is known as tics. Tics are semi-purposive, sudden, jerky, repetitive movements. Sudden, jerky, repetitive movements which are semi-purposeful and which can be suppressible to one extent. But when they suppress it, they will have an inner arch. That is a tics. We'll explain all this later again. Akathisia is inner arch to move, where the patient cannot sit, patient keeps on doing some activities, and that is totally different. That usually seen after antipsychotic use, or sometimes SSRIs in Parkinson patient can trigger akathisias. So again, the major movement disorders: tremor, chorea, balismus, dystonia, myoclonus. These are 5 major movement disorders. Tics and akathisia are not that common in, at least in adult general medicine. Tics are more common in pediatric age group, but you can see adult onset tics also. So that is what. So tremor is repetitive, unidirectional, very symmetrical movement. So this is tremor. This is chorea, where you have random movements, multiple movements, multidirectional, non-repetitive. Then balismus is large amplitude, flinging movement, proximal movement. Athetosis is a chorea-like but more distal writhing movement, slightly more repetitive. Dystonia is, this is dystonia, posturing, sudden, like posturing or some jerky movement. And myoclonus is sudden jerky movement. It can be repetitive or non-repetitive, depends upon type of myoclonus. Then tics are very repetitive, very fast, sudden movements, which the most important point differentiation, the confusion happens many times with myoclonus and tics. Tics are sometimes very fast movement. I had some video, but I could not show because it shows the entire face of the patient. I cannot show it. That is why I didn't show it. So that are tics. Then so that were the major movement disorders. So we covered about the major how to approach movement disorder is like rhythmic, repetitive, predictable, axis joint, and also you see the speed of the movement. That is also important. The most speed is myoclonus and tics, while dystonia is the slowest movement. Okay.